Hello, everyone. Happy Thursday. Welcome. I'm Michael McNutt, Wheaties Director of Education and Events, and as part of the Road to Interoperability and Prior Authorization series, this is the Pair-to-Pair API. It's my pleasure to introduce Robert Tennant, Wheaties VP of Federal Affairs.
Thank you, Michael. Let me add my welcome. Today we have a very exciting program, and the timing couldn't be better because the interoperability and prior auth rule was released in its final version in today's federal register. So it gets down to only a few hundred pages instead of the 800 or so in the original version. So you can go to the next slide. So I wanted to let folks know, in case you aren't overly familiar with WEDI, I'm going to go very quickly through just a few slides. But we were named in HIPAA, the legislation, hard to believe, but bipartisan healthcare legislation passed in 1996. In fact, Dr. Lewis Sullivan, many of you may not know this, brought into his office some of the leaders in healthcare and asked them to write a report that would seek to improve the efficiency in how data is exchanged between health plans and providers. And that led to the creation of the working group for electronic data interchange. They produced two reports in the early 1990s, which were translated into legislative language, which made its way into HIPAA. And so we were named in that law as an advisor to HHS, and we've performed that role ever since. In fact, we have CMS and ONC on our board of directors currently. Next slide. So how we do our work? Well, we work collaboratively, just like this program here today. We seek to bring the industry together through our work groups and listservs. We have, of course, multiple conferences, forums, and webinars throughout the year. We work collaboratively to develop responses to federal initiatives, whether they be proposed rules or requests for information. You can see here we really span the wide breadth of healthcare, including practitioners, hospitals, state government, federal agencies, health plans, vendors, and we're getting more and more engaged with the patient community as well. Next slide. How we do our work? Well, most of it is done through our work groups, sub-work groups, and task groups. And you can see here 18, a wide variety of topics that each of these oversee. I would encourage you, if you're not involved in these entities now, get involved. And as a reminder, if your organization is a member of WEDI, everybody in your organization is a WEDI member. So if you have a colleague that has a particular interest and expertise in one of the HIPAA transactions, we have a sub-work group for them. Again, you can go to our page on our website to learn more about each of these work groups and sign up with Samantha Holby. Next slide. So I wanted just to walk through today's agenda. We'll go through till about 3:30. We really have a blue ribbon panel of experts today, and I am in particular very pleased that our good friend Ferris Taylor, who is executive director of the HCEG, that has stepped up to be moderator for this event. So thank you, Ferris, and we're looking forward to a very spirited discussion. Before we get to that panel, we'll have Shauna Hartman, who is interoperability lead at the Office of Burden Reduction and Health Informatics at CMS. She'll be followed by Mark Scrimshire, who is Chief Interoperability Officer at Onyx Technology. So we have one of the co-authors of the final rule, and then we've got one of the national experts on the technical side of the rule. And then we'll switch gears and really hear from, again, this blue ribbon group of individuals to give their perspectives on this very challenging requirement. At the end, we will shift gears, and EdFX, our good friend and partner, will provide a very high intensity look at this rule, and you'll want to stick around to hear that as well. So next slide. So we couldn't produce these types of educational programs without the wonderful support from our vendor partners, EdFX and MCG, and we put the description of each and the website. But I can tell you that these companies both have been long-time supporters of WEDI. I have heard nothing but wonderful reviews from clients of both. If you are interested in trying to solve the riddle of this final rule, I would strongly encourage you to reach out to these organizations. Next slide. This is going to be an interactive program. Yes, we have a wonderful group of panelists, but we also want to hear from you. Using the chat function, I would strongly encourage you not just to ask questions, but if you have a comment or if you have a suggestion, we're here to learn. And that's really the strength of WEDI, is by bringing folks together. We learn from each other and we're able to ask each other questions. So use that chat function. And as always, the slides and recording of the event will be sent to your email address after the program, and it'll allow you to share this with your colleagues that weren't able to join today. This is the second of an ongoing series doing a deep dive into this very important final rule. We had the pleasure of having Alex Muggy from CMS give us an overview of the entire rule January 19th, and that is available on demand, free of charge. And again, it's something that you can pass around to your colleagues in your organization to learn more about the rule. On February 15th, next week, we will be looking at the patient access and provider access API. And then we'll switch gears and delve into the prior authorization components of the final rule. We'll start with a discussion from the payer, provider, and patient perspective, and then we will bring in the EHR vendor and early adopters and vendors perspective. And in particular, we are really pleased to have some early adopters of the API to be able to share their experience with you. We'll then talk about the rule from the perspective of a small provider and then small payer. So give them a chance to understand how this final rule will impact those types of organizations. And again, all of these are free for WEDI members. If you're not a member, you can sign up for the full bundle or individual events. Next slide. And for WEDI members, I would strongly encourage you to join our emerging technology work group. We're going to do what Ed calls post-game shows. So it'll give you a chance to share your perspectives. The goal with these emerging tech meetings is really to identify some outstanding issues, in particular, that we may want to ask CMS for guidance on. So it's an opportunity, again, for you to share your perspectives and your organization's views on the rule. We'll get additional feedback. We'll talk about potential solutions. And again, try to identify some areas that need further clarification. You want to get involved in that, of course, reach out to our own Samantha Holvey at sholvey@wedi.org. So with that, it's my pleasure to welcome Shauna Hartman from CMS to give us a really good overview of this particular section of the final rule. So Shauna, thank you so much for joining us here at Weedy.
Thank you for having me. And as he's just said, I will be presenting an overview of the payer-to-payer API policy in the CMS interoperability and prior authorization final rule. Next slide, please. So just a quick overview of our rule that was released on January 17th and as you already heard, was published to the Federal Register today, the CMS interoperability and prior authorization final rule. The impacted payers in this rule are required to implement certain provisions generally by January 1st, 2026. And in response to stakeholder comments on the proposed rule, the API implementation deadlines are January 1st, 2027. Next slide, please. And I do just want to note that we also had our first interoperability rule that was previously published in May 2020, the CMS Interoperability and Patient Access Final Rule. And that rule focused on patient access to health information through a patient access API and also required provider directory information made available through a FHIR API. Next slide, please. And specifically in regards to the payer-to-payer policy, there was also a payer-to-payer policy in that rule. However, after finalizing that CMS interoperability and patient access final rule, we did hear from multiple impacted payers and stakeholders that because we did not specify a technical specification for the data exchange requirements in that policy, that it was causing implementation challenges. So in December of 2021, CMS published a Federal Register notice announcing that we were going to exercise enforcement discretion and not enforce the payer-to-payer data exchange requirements until future rulemaking. So this future rulemaking here for the payer-to-payer API policy did rescind that previous payer-to-payer data exchange that was previously finalized, as we did not want industry to develop multiple systems in a non-API format. So in this final rule, we are requiring impacted payers to implement and maintain a FHIR API for that payer-to-payer data exchange. And that is what I'll be discussing today. Next slide. And hopefully you all were able to attend the first Weedy webinar where Alex Muggy did provide an overview of the final rule. If not, here is a list of the provisions, the impacted providers and impacted payers in that final rule. I just do want to note a few differences for the payer-to-payer API from the other APIs in the final rule. The payer-to-payer API does not include provider remittances and enrollee cost sharing, and also does not include denied prior authorizations to be exchanged, as we did not feel that those were beneficial for continuity of care purposes, which we were focusing on for payer-to-payer data exchange. Payer-to-payer API also does include unstructured documentation that is submitted by a provider to support the prior authorization request, unlike the other APIs in our final rule. We believe that there's more time for payers to include this type of information and that this information could support the patient's continuity of care. Also, the data sharing requirements as far as timeline, payer-to-payer only requires sharing of the previous 5 years of data. We did hear concerns from commenters and stakeholders regarding the technical feasibility of transferring that full longitudinal record through a payer API, and believe that 5 years of data does provide that ample information to improve the continuity of care and support chronic condition management. Next slide, please. All right, so diving into the payer-to-payer API. To support continuity of care, we are requiring that impacted payers implement and maintain a FHIR API to make available claims and encounter data, again, excluding provider remittances and enrollee cost sharing information, the data and data classes and data elements in the US CDI, and information about certain prior authorizations, excluding those for drugs and those prior authorizations that were denied. They're required to share patient data with a date of service within 5 years of the request for data. And we believe that this will help when patients change from payer to another payer to ensure that patients have continued access to the most relevant data in their records. The prior authorization data that must be provided through this API is the status of the prior authorization, the date the prior authorization was approved, the date or circumstance under which the prior authorization ends, the items and services approved, and related structured and unstructured administrative and clinical documentation that was submitted by a provider. For this API, we have finalized an opt-in process for patients to provide permission under those requirements. An opt-in framework means that a patient or personal representative needs to affirmatively permit the payer-to-payer data exchange. There is a requirement that impacted payers must establish and maintain a process to gather patient permission for this data exchange no later than 1 week after the patient's coverage begins with that payer. And impacted payers must also have a process for patients to opt into this data exchange at any time after the start of coverage, or if they've already opted in, to opt back out at any time. The payer that requests the data from the previous payer has to have identity authenticated and include an attestation with the request that the patient is enrolled with that payer and that the patient has opted into the data exchange. I will also note that the latest published version of the PDEX IG STU 2.0.0 does include a mean for a payer to communicate that a member has opted in through a FHIR consent resource when requesting that data from another payer. When there is concurrent coverage data exchange, so with 2 or more payers, impacted payers are required to exchange the patient data within 1 week of the start of coverage and also at least quarterly. The requirements for the payer-to-payer API must be implemented by January 1st, 2027. Next slide, please. There is also a requirement for patient and provider education. Impacted payers are required to provide plain language educational resources to patients that explain the benefits of the payer-to-payer API data exchange and their ability to opt in. At a minimum, this education must include the benefits of the payer-to-payer API, their ability to opt in or withdraw that previous opt-in decision, and instructions for doing so. Payers must make this information available to patients when requesting their opt-in decision, and payers must also provide this information to patients annually and must be made available in an easily accessible location on the payer's public website. Next slide, please. This final rule also specifies technical standards that will be used in building and maintaining each of the APIs. CMS is allowing flexibility for payers wishing to use updated versions of the standards in this rule, and CMS is strongly encouraging but not requiring the use of certain implementation guides to support the API development. And I will go into more details about those specific ones that we are requiring and recommending for the payer-to-payer API. Next slide. So this table here outlines all of the required API interoperability standards, but I will be focusing on payer-to-payer specifically, which does require that US CDI is shared, also requires the use of FHIR Release 4, the HL7 FHIR US Core IG 3.1.1, and the HL7 FHIR Bulk Data Access IG STU1. I will note here that in the ONC's HTI1 final rule, ONC did finalize updated versions of several standards, and one of those included the US Core Implementation Guide. ONC also finalized expiration dates for when a version of a standard may no longer be used, and we do acknowledge that the versions required in our CMS final rule differ from those finalized by ONC. Again, specifically for this API use case, that is the FHIR US Core IG, and we do intend to align with the updated versions through future rulemaking. I will, however, note, though, that through the SVAP process and through our ability to allow payers to use updated versions of the standard, you are welcome to use the updated versions of those implementation guides already. You do not have to wait until we propose and or finalize those in future rulemaking. Next slide, please. And this table here lists the recommended implementation guides for each of the APIs. So we have recommended several implementation guides for the payer-to-payer API, including the use of the Carrion IG for Blue Button, STU 2.0.0, the HL7 DaVinci PDEX IG, and also the HL7 Smart App Launch IG 2.0.0, specifically support for the backend services authorization. Next slide, please. And there are additional resource links here as far as the final rule fact sheet and our OBRHI website, and as well as technical standards and implementation support links at the bottom as well. And then next slide, please. All right, and I know that was very quick, and I'm sure you all have lots of questions. And that was a very high level deep dive into the payer-to-payer API. But as always, if you don't get time to ask your question today, please do email us, cmsinteroperability@cms.hhs.gov. We are reviewing all of the questions that come into the mailbox and providing written responses to those questions as well. We are also using those questions to inform our frequently asked questions that will be published at a later date to our website as well. Thank you again for having me today.
Great, thank you, Shauna. And we actually do have a question from our good friend Janice. She asks, what about denied requests, PA requests that are still under appeal? She argues one of the purposes of sharing prior auth information is to limit the need to redo PAs. So it seems like including the relevant pending appeal requests would, with underlying clinical data, would make sense.
Yes, that is a great point. I don't think we specified that specifically in the rule. If they were pending, in a pending status, pending prior authorizations, that would have to be shared. I will have to look into this a little bit more about whether it's denied and then under appeal, how that status works a little bit more. And if you want to send this question to our CMS interoperability mailbox, that's a great question, and we will reply back to you there in writing.
Excellent. I appreciate that. And thank you again for sharing your expertise. Much appreciated. And with that, we are going to invite Mark Scrimshire from Onyx Healthcare and PDEX to give us his perspective on the payer-to-payer API. Mark, thank you so much for joining us today.
Thank you, Bob. Actually, Shauna, you did a great job. You covered a lot of the technical, so let me try and put some color around that. So what are we actually doing around the FHIR specifications for the payer-to-payer API? PDEX, in its STU2 version that was actually published, had a single member match operation that could be used for payer-to-payer exchange. What we're in the process of finalizing, so it will be part of a PDEX STU update, is to take that, the main workings of that operation and convert it to a multi-member match so that a payer will be able to submit a query to, I'll use the term new and old payer. So a new payer will be able to query an old payer for one or more members, and the data that they would provide will enable the old payer to determine whether they can actually match that member and comply with the consent directive that the member provided as part of that exchange. This is going to be what we would term a member-mediated exchange. So the difference with, you could do payer-to-payer exchange today using the patient access API, but the member has to have accounts with both payers and has to actually manage the whole process of exchange. What we really see as the primary use case here is when a member changes from one plan to another, that they will, during their enrollment, they will be able to indicate that, yes, they are opting in to sharing their data by asking the new plan to go and retrieve the data from their old plan. So that API will, though, also be designed to deal with the situation where a member has concurrent coverage with more than one plan. So the first step is going to be to perform this match. And to do that, there are really going to be three major pieces of data that will need to be provided. This is going to be based on a deterministic match rather than a probabilistic match, because what was decided a number of years ago when we were at what the first CMS Connectathon is, the general principle is that if a member is interested in getting their data from the old plan, that they will provide the new plan with basically their coverage information from the old plan. So typically that's the data that you receive on a coverage card. That will be supplemented by some patient demographics. And think about this, a member could be moving from one plan to another, and maybe they're changing their name. These days, maybe even changing their gender. So they would provide the information as they were registered with the old plan. Then the third part is, because we're dealing with two covered entities, is really an expression of consent. So we have defined in PDEX and in the Health Record Exchange IG, a consent resource that can reflect that the member is opting in to having the new plan collect their data from the old plan. And they, because of various requirements about set data sensitivity, they can either choose to have all data returned, that's both sensitive and non-sensitive, or they could say just the non-sensitive data. So when the old plan receives that package of data for a given member, they can take the coverage information and see whether they recognize that coverage. That may get you down to, at worst case, possibly a family unit. The patient demographics then would help to get to an actual member that is asking for their data to be transferred. If they get a match on that, then they would want to check the consent in order to see that they can comply with the consent. And there we get into the technicalities of, is the data segregated in the API to be able to identify sensitive from non-sensitive data? So we've covered really the second phase of a three-step process a payer would go through in being able to exchange data. The first step is going to be obviously making a connection between these payers and getting a set of credentials that will allow them to access these secure APIs. To then perform that member match. Now, when the member match happens, the old plan may be processing a list from the new plan of hundreds of members. They'll basically create a group resource for all of the matched members. And they can also identify those members that they couldn't match and those that they couldn't comply with the consent request. All of that data will be returned to the new plan. The new plan will be able to take that list, that group resource, and its ID that relates to the members that they successfully matched, and will request an access token from the old plan and perform a bulk FHIR API export request for that set of data. Now, as Shana mentioned, that will be limited to 5 years worth of data. That's a subtle difference from the provider access API that we'll talk about next week. What's actually going to be in the set of data that's returned for a member? You'll have basically the claims and encounter data, but it will be without any cost data. So with PDEX, we are working with the Karen Alliance, who developed the Karen Blue Button IGs, to create a non-financial set of profiles so that can return the appropriate data. We deemed that was a better approach because the Karen Alliance spent a lot of time working out how to represent the explanation of benefit resource for all of the claims and encounter data. And so they're in the best place to actually work out what data needs to be redacted. The API will also return clinical data. So that will be US core. One of the things that will be happening, I can't speak for Da Vinci directly, but I know through being engaged in authoring payer data exchange, we're on a pretty rapid program to identify the issues with migrating from US Core 3.1.1, that's named in the rule, to US Core 6.1, which is going to become the baseline as of 1/1/26. So data, the clinical data, will ultimately follow US Core and is likely to be US Core 6.1. Then the other piece in this is the prior authorization profile, and that is already defined in PDEX's STU2 version. So that will reflect any active prior authorizations and any prior authorizations that have changed status within the last year. So that includes approved and denied prior authorizations. So that API capability, we are looking at having at least two types of query. One is that you can simply ask for all of the data and it will bring back the 5 years worth of history if it's available. But we're also looking, because of the need to support concurrent coverage, is to allow dates to be provided to provide a window on that data. So in the case of concurrent coverage, where plans should be exchanging data at least quarterly, they would be able to go in and request the data initially, and then request at a later date the data that is new since that last check. The advantage of that approach, why we want to include that, is that if you think about it, when a member moves from one plan to another, there can be a period of runoff on the claims. And so it makes sense that maybe the new plan can go back to the old plan and make a subsequent request to fill in the gaps of data that's been completed, maybe after the member actually, their plan terminated, but data was still being processed in terms of claims, etc., from providers. We actually, in the PDEX STU2, we provided in the payer data exchange pages a lot of guidance around the consent and also the period for which a token should be available and active, so that we try to stay in line with a lot of the guidance that came out of ONC to make this a relatively straightforward process for payers to implement. In terms of the APIs, we are still finalizing these. There will be an update to PDEX because we need to incorporate this move to US Core 6.1 at the very least, but we need to add in the finer details of these exchange paradigms, these bulk APIs. And so I very much encourage you to get involved. PDEX has a community workgroup meetings on Fridays at 1 p.m. Eastern. I'd encourage you to do that. I would also say go to the HL7 FHIR implementation guide sites, just search for FHIR PDEX, and you can look at the CI build that we are continually evolving from week to week. So with that, I think I can pass back to Michael or Rob to take us to the next phase, I think, which is the panel.
Excellent, Mark. Thank you so much for sharing your expertise. And with that, we are going to shift gears and invite the moderator, Ferris Taylor, to maybe first introduce the panel and then get right to it. So Ferris, the floor is yours.
Thank you, Rob, and thanks to each of you attending the discussion, and especially thanks to Shanna and Mark for kicking this off. And we are fortunate that both Shanna and Mark will be able to stay on for the panels. So additional questions and like that, please put them into the chat function. I'm going to ask each of the panelists, as they're listed on Rob's screen, to introduce themselves, just so you get their voice connected with it. And in the meantime, I'm going to ask Michael to put up for us as a panel a quick poll so that each of you as attendees can tell us where you're at with respect to considerations on implementing the payer-to-payer APIs. So Michael can put that up, but let's start with Samantha and go down through the list, and each of you introduce yourselves.
Great. Thanks, Ferris. And thank you to Rob and Michael and the WEDI team for inviting me to be part of this panel. I'm in week 5 or 6. Can't remember exactly at AHIP. So I certainly got off to a strong start with this rule being released, and certainly a lot to go through. So just in terms of a high level sort of response, what are we hearing from our members just initially off the bat? And I think there's certainly a lot of appreciation for some core elements that CMS addressed in the final rule with respect to both creating that longer runway for implementation. We're hearing from our members, there's going to be a lot of learning in this process. And WEDI has been also one of those, just great sounding board organizations to bring the industry together to talk about this. So thankful for that. And also very appreciative of the change that was made to reduce what impacted payers have to exchange to only 5 years of data. We thought that that's really going to be meaningful, and agreed with CMS's comments around how do we make sure we're not putting unuseful, I won't call it junk, but unuseful information, because really what we're creating is an ecosystem, right? As we think about how these different APIs and the information that's being exchanged plays off of each other. I would say we are at about the 5-yard line when it comes to the questions pouring in as our members are really starting to think brass tacks and sort of how the rubber meets the road in terms of implementation. So some of the topics that folks are raising, and I know we're going to get into more detail on the technical side from other panelists, but really around that unstructured data, prior authorization data element, exchange with non-impacted payers. And what does that sort of really mean, and with whom and how much? And then sort of issues around the opt-in and concurrent payers, and just ensuring, I think at this stage, that plans, the way that they read the rule is how CMS intends it. So we're really looking forward to the ongoing relationship there in terms of getting these questions to CMS and having listening sessions and having operational dialogues around what is the information that plans need to really be able to do this well and to optimize the value. I don't think anyone views this as an exercise in playing to the test. I think to the extent that we're building this infrastructure, we want to ensure that it's bringing value. It's obviously bringing value. We want it to bring value to the plans, but ultimately we really want it to bring value to the patients. And that's the primary goal here. So I will stop there, Ferris.
Thank you, Samantha. Karuna, where's Blue Cross Blue Shield Association? Introduce yourself and a very quick, where are you at? Where do you see your members?
Sure. Hi, everybody. Yeah, absolutely. Hi, everyone. My name is Karuna Rolani. I'm the Business Interoperability Lead on the Health Information Technology team at Blue Cross Blue Shield Association. So as many of you might know, we work with, all of the Blues plans, and we're sort of the arm that ties us together as a brand. And so as part of that, we offer various services, but essentially, you know, each plan themselves is going to be expected to adhere to these regulations in addition to us as a system. So I think we are excited about the opportunities here, and I think many of our plans began the work when it was originally suggested a few years back, and so it's resurfacing now in more context of kind of some of the work that's already been built out with patient access and provider directory. And we're along the journey of the learning curve just like everybody else, and we know there's things that we can do today to support, you know, driving alignment with the standardization, with the implementation guides. You know, they're recommended, but what can we do to really drive engagement with Da Vinci and some of the groups that are offering opportunities for testing and connect-a-thons? So those are places that we feel we can support plans in terms of where can they make impacts that will help move us forward as a system in this new payer-to-payer world. I think many of Samantha's concerns are similar to our concerns, and there's things that we do need to figure out as it relates to our policies and some of our privacy and trust frameworks, and you know, the security mechanisms, and there's many infrastructure considerations that we'll still need to kind of work together to determine the best way forward. And then there's also things that the industry needs to figure out that we all know as well, and that will influence kind of our role as the association. You know, in terms of whether plans prefer to do point-to-point versus network exchanges, where will things like endpoints live? So I'm sure we'll talk more about that, but we're all very excited, and I think that we're excited we have forums like WEDI to have these conversations and really hammer out some real mechanisms to move forward. So thank you.
Thank you, Karuna. And I, at least on my screen, I think Michael's sharing the poll results. I think next on our panel, Ron Wampler is in that 8% category that's close to complete. Maybe I'm overstating, Ron, but introduce yourself and tell us what Aetna CVS is doing and what your experience has been very quickly.
Yeah, sure. Thanks, Ferris. Ron Wampler, I'm the Executive Director of Interoperability with CVS Health Aetna. And actually, we've been involved with these rules since the beginning, since 2020. To the best of my knowledge, we were actually first to fully implement payer-to-payer, inbound and outbound processes. I haven't met any other payers that went before us, which was in before 1/1/22. And we've been live ever since. So we are fully implemented, I would say the 4%. So we're very vested in this. It's very important to us. There's a lot of value in you know, this process, and we're really looking forward to building it out. As Mark Scrimshire could tell you, we've been involved with the consortiums with Da Vinci, PDEX, and others from the beginning. So that's really important as companies move forward to utilize these resources and to implement in a standard kind of way, and to provide input to make sure that we're all working together in this ecosystem. So, yep. I'm going to say 4%, Ferris, because we've been there since the beginning. We see the value in this, and we continue improving it, and just really excited for the future.
Terrific. And I'm going to come back to Michael and Richard, but I'd like to hear introductions from John and Dennis. I had to strong arm Dennis to join the panel only because he said, "Oh, I don't want to." We're still getting started. So John, introduce yourself, San Francisco Health Plan, and then Dennis, Health Partners, and tell us just a little bit, and then we'll go on into questions with respect to you as panelists. John?
Yeah, John Arskodiak. I'm the director for San Francisco Health Plan. My title shows a lot of what I do, but my biggest focus is on all of the EDI and interoperability areas. And we're a small plan. We're just geographically city and county of San Francisco, but we still have to meet all the same requirements. And you know, I saw the interoperability requirement when it first came out. We had to do it. We're a small plan. We had to do it cost effectively. So what we went to RFP right away, looked at what the future would be with payer-to-payer, and you know what we could do, and also we partnered with some of our other Medi-Cal plans in the state to share, and we all signed with Edifax. You know, so I'll do the Edifax commercial. So they've been a great partner, and then we've built upon the base product. So the state of California has just recently, or this year, mandated we have to, you know, provide payer-to-payer API. So we're live with it as well, and that was this year. They even tied it to our contract. So didn't give us a lot of choice if you want to stay, being a Medi-Cal plan. With that, we went back and it was actually fairly easy, but the infrastructure we put in initially was we created our own patient index, in the interoperability data store with Edifax, provided them the table. We actually provided to our own eligibility files to build that. So then, as we were talking about earlier, you got to make sure you identify the member, and then you may have a group of members. So with our index, it was foolproof. And and that also worked because we have disparate systems. We're normalizing data that don't share a key field. So that made it easier to do this. And we also had the ability to do the bulk load of the 5 years. We, again, have had no issues since we've gone live. We do have not a lot of usage. Again, we're 180,000 members, Medi-Cal, so they're not exactly, the member type that has access to computers, and they're mostly on their phone. It's not something they look at because of, that's just our member base. But we do have people, we do have members using their third-party apps. We haven't had any payers come to us yet, but also to what we did with the payer connectivity. Being a small plan, small IT shop, we partnered with CAQH. They're providing our attestations. We're exposing our endpoints using them. So this way, it minimizes the impact to the SFHP IT staff, my team, to set up individual connections. So we're looking at working with the hubs to connect, expose our endpoints, and spread it. It becomes very cost effective. We meet the compliance. And actually, too, I'm also working with our Medi-Cal plans. We have Edifax, the group of us get together and we share how we're all doing this. So we are doing this all in the same method. And then this opportunity, too, allows me to share what we're doing to others as they're trying to come up.
Terrific, John. Really appreciate that, and we'll circle back with a number of questions. Dennis, you don't represent that 4%, I gather, or 8%. Tell us, introduce yourself, and just tell us a little bit about where Health Partners is at.
Happy to do that. And so I'm, excuse me, I'm Dennis Zuzek. I lead IT for Health Partners. And for those of you who may not be familiar with our organization, we insure about 1.3 million members. We provide medical coverage for them. We have another 500,000 of dental members, and then we deliver patient care to about 1.2 million patients. So we have dealt with interoperability in both our care delivery business as well as our payer business. And so far, we are live on a third-party solution that delivers interoperability with consumer applications. And so our intent is to build out our payer-to-payer capability on that, and then expand the integration that we have with that provider. So today, the integration that we have is really one way. We expose information through that provider to patients. Going forward, with payer-to-payer, we'll be bringing that information back in and making it part of our data ecosystem. And I think too, some of the points that have been made, one of the things that we are really curious about and will be watching as this matures is just, how we credential our trading partners and how we can do that effectively and sustainably, and the security, and then the cost structure. So, we have a cost with the vendor. If there's a data movement and exchange cost through, TEFCA or whatever organizations are involved, we just need to keep track of that and make sure that we and our members are getting value out of that. So that's where we're at right now.
Thank you, Dennis. And let's have Richard introduce himself, our other health plan on the panel, South Carolina.
Hi, so my name is Richard Abercrombie. I'm a lead developer for the FHIR team for Blue Cross Blue Shield South Carolina and Palmetto GBA. I've been around, FHIR since late 2020. So I was involved in a lot of the implementation side of the patient access and provider directory for the initial mandates. Since then, I've definitely been involved in a lot of the, the connectathon space for, future testing and a lot of the implementation guide testing, as well as, doing a lot of the groundwork for the new mandate for, prior authorization. So definitely glad to be here, and
good to have you, Richard. Thank you. Michael, and then Artem, and then we'll jump into panel questions.
Hi, I'm Mike Gould. I'm Associate Vice President for Interoperability Strategy with Z Omega. I've been with Z Omega for about a year and a half, and have experience on the plan side with Karuna at the Blue Cross Blue Shield Association, as well as other Blue plans. And Z Omega, in the short time where we've had to deal with payer-to-payer exchange, has implemented payer-to-payer exchange for a couple of our clients. Like some others have said, we've seen limited uptake on it, but we see the value for plans that have large shifts in membership at different times, where an organization, an impacted organization under the rule, may come under the management of another organization, and at the turn of a calendar, there's a large set of members that need to exchange their data. And for the plan that they're going to, it's really important for them, for that plan, to know what they can about their members, their new members that are enrolling, so they can serve them well. So that little story on the business side couples with a little bit of tech from the provisions of the rule that call out bulk FHIR. So I'm not going to dive too much into that right now, because there's a whole bunch that Mark Scrimshire could talk to you as well about that. But back to you first.
Thank you. Artem?
Okay. Hello. Hello, can you see me? My name is Artem Sopin, and I'm product manager at EDIFX. So I've been involved into FHIR development and research since probably very beginning. So far we have implemented multiple IGs, including pair-to-pair, and basically our strategy is to build a cohesive solution for the industry that includes pair-to-pair, patient access API, we're looking towards provider access API, pre-authorization, and everything together. It's like one huge ecosystem for us that includes all scenarios that helps not only health plans, but also to members. So we've enabled multiple plans in terms of the pair-to-pair. We have tested the connectivity. We tried that on real data. I'm talking right now about STU1. So for those who's familiar with the IG numbers, and basically we have proved that the concept is workable, and we are working on the continuation. We participate in Da Vinci discussions, because we are now not on the final point, as Mark Scrimshire mentioned. We are working towards like a group data exchange. It's a continuation of like a single member exchange that should simplify things. And we are really excited about what's going on Firewall, and it simplifies literally everything for members and for health plans, like having the latest and greatest data in a kind of in a matter of minutes or maybe hours, depending when you execute the exchange, like pushing all this data to the new plan, and the members will have all their data right away without any need to to collect any paper prints, anything, like all this old stuff, everything electronically, everything is up to date, and everything in the new plan. So this scenario, which is important for me personally, I believe that will be also connected like with future provider access API. So I look at it as a one cohesive scenario. You change your plan, you get the latest data, you schedule an appointment with the provider, and everything you need for this provider isn't there. You can open your mobile app, connect to your account, and see all this data there. So it's not like one isolated use case. I like to think about it as a complete ecosystem that addresses multiple problems, and peer-to-peer is just one of the major pieces in this ecosystem.
Terrific. Thanks, Artem, and thanks for those introductions. I'm going to ask Michael to change the screen so that we can see all the panelists, and we're going to try to keep track of each other as panelists raise their hands to coordinate a discussion as we look at the benefits, why peer-to-peer, what are the benefits, the challenges, what's the experience to this point, and such. So I'm going to send a quick chat, but encourage each of you as attendees as well to enter your questions. So let's kick this off. Why, for each of you, why are we talking about peer-to-peer APIs, and what do you see as the benefits to your organization? Each of you commented a little bit in the introductions, which got us started in the discussion. But why are we talking about this?
I can jump in. I don't know how to raise my hand, Ferris, if you'd like.
It's under
Michael,
under the more part, reactions. Just raise
got
your
it.
hand.
I think
Everybody
Michael
has
beat
something
me
to say.
it.
So
everybody
start us off, Ron, and then we'll go to Michael and Richard and Artem.
There's so many people, so I'll keep it extremely brief and try not to steal everybody's thunder, but it's extremely important as we just heard. This data is about moving the needle on patients' healthcare, right? This data is very valuable. That's the primary thing. There's so many levels of reasons why this data is important, why we need to enable these processes, why it's important to our company to be out there first doing this, because it is so important for that member's healthcare. It is so important for all the things we use this data for. So I won't belabor it, but that's why we're interested, is because the data has so many uses and all sorts of positive use cases.
Perfect. Michael?
Yeah, I think it's best to consider that data that patients can get from their providers gives that depth and relevance and timeliness. But that only gives the patient the one provider's data. By working with their payers, they get a longitudinal record. So putting the two of those things together really gives a comprehensive view of their health history for the patient that they can take when they go into new care settings, particularly.
Richard, Artem, and then Michael, or Mark, I'm sorry.
Yeah, absolutely. So, yeah, of course, data is king. Data allows us all as an industry to work together towards patient outcomes. And I think, that can go in multiple different directions, right? You talk about, the patient being able to access their data through a patient access API, or a provider being able to give better outcomes to a patient for having an accurate and up-to-date record of the patient's history without having to use faxes or other methods, and as well for payers, for instance, having the complete immediate access to the patient's historical data can allow better outcomes for adjudication for prior auth, for instance. So I think all of these as was mentioned earlier, they interact very well with each other, and I think the peer-to-peer aspect of that just makes sure that that data is available in a timely fashion for all the other use cases involved. Thank you.
Artem, then Mark?
Yeah, I see it as a full win-win for members and for health plans. First of all, from health plans perspective, when you import data from the old health plan, you have much better knowledge of like a history for this member. You have, let's say, previous prior authorization records, so you don't need to kind of repeat that. You might find certain clinical records for your clinical decision and say, hey, actually, you already have this MRI, you already have this X-ray, you already have something like that. Why would you repeat that as a member? Here is your record. And I can just shoot it out to provider, or provider, you can use provider access API to connect to these records and just pull. So it's a savings. But for member, which is important, it's a one place to store the data. Just remember yourself 5-10 years ago. You could find your medical records at one clinical facility. You might have something like printed out on paper. And if you have a new visit, you need somehow pull everything. You don't know even what to pull together. And you go to a certain facility saying, hey, I had something in the past. I don't even remember what. Now it's a completely different story. You have, I'm from this health plan. I'm with this payer. This is kind of my insurance card. And you have this kind of your kind of coverage ID, which means provider can just grab it immediately and see the whole history. And it's a good for everyone. That's why I call it sort of win-win type of scenario. And even if you travel internationally or travel inside the United States, you can, using the patient access API, you can always, using some mobile app or similar, you can always connect to your account. And what is important here, what is the difference? This account is at payer side. It's a more centralized place than having multiple accounts to multiple, clinical facilities like hospitals and stuff like that. They give out accounts for you. It's not a problem, but I even don't remember how many I have outside, like in one hospital, another hospital. I visited multiple things. I don't even remember how to restore that. But once everything gets pushed into one single payer, it's the best place to store it that will remain there for years and years, and you will always have access to it. So that's why I call it win-win for payers and members, and I would say even for providers. Thank you.
Thanks, Artem. And Mark, as you respond to those benefits, there is also a question that I can.
Yeah, I see that. I can.
Okay, you can address that while your comments,
yeah.
and then let's go to somebody had their hand up. John will be next.
Okay, so the use of the data, initially, California mandated that all plans providers have to participate in the state data exchange, and that required where I partnered with a QHIO, and this eventually goes to the future API for the data exchange that's like 4 years down the road that we have to connect using FHIR. Well, I use my FHIR data. I use my normalized to provide to my data, my QHIO. Now I have with the payer to payer, and I start getting more and more of that data from other payers. I can share, I'll have that in my feed that goes to my QHIO. That then normalizes and presents the data back, and I have that full record. And then my QHIO has a portal where we can see that data not only from my plan and also the payer to payer piece, but also any of the other plans. So exponentially the data grows that can be shared throughout the state. Now, of course, only 1/3 of those mandated have participated and made the date. We made the date. It's working, and also doing the bulk FHIR extract to provide the data, then having the API access daily for the updates. I keep everything current and have that view. Now my internal staff don't have to log in to 3 different backend systems. They can just use the single portal to see all of the normalized data in a common presentation.
Terrific. Mark, let's go back to you.
Okay, yeah. Many people have probably heard me say this, but I describe the payer as data as basically the connective tissue of the patient's care journey, because it connects so many different parts of the health system for that member. And that's really the advantage. The other thing I'd say, in a practical reason, why would a payer want to engage in this and actually pull data from other sources? Well, one is the member is opting in, can ask you to do this. So you really need to go get this. But I remember reading recently, and I'm hoping I'm not hallucinating, but I think Medicare has put out guidance that says when a member changes from one plan to another, you should not be doing a prior authorization on anything for the first 90 days if it has already been approved by the prior plan. So in effect, you need to know what those prior auths are that are sitting in the patient access API or the provider or the payer-to-payer API in order for you to use that to inform your decisions about, am I going to require a prior auth? So there's a number of things that CMS is doing that is really driving us to making sure we are sharing data for the benefit of members.
Terrific.
So,
Go
and
ahead,
do you want
Mike.
me to answer the question
Please.
on the the question was really what it's unclear about unstructured prior auth documentation. So Richard, hopefully this will answer it. My reading of the 822 pages is that CMS will require, really is encouraging payers to incorporate the structured content, clinical content that is used to basically arrive at the decision for a prior auth. They are not requiring unstructured content to be incorporated. To me, that reads as if you think about the prior auth process itself using FHIR is going to ask for data elements out of the FHIR API. So if it's returning that data, they're using it in the decision, effectively you should be pushing that into the patient access API in support of the prior auth.
Terrific. And we have a question in chat, which I'll put out to the group. How does a new managed care organization identify prior insurers? And Michael,
I think
we have expertise here.
Well, Dennis actually hit one of the nails on the head, right about we've got to work out as a community how we can all get connected. We have got to work out how we can connect with different payers at scale. That means we've got to be able to find the APIs, and then we've got to be able to make an automated request to say, give me access, you can trust me. And I think this would be my call to WEDI as a sort of convening organization. This is where we need to get together as a community and work that stuff out so that you can look up a directory, find the endpoints, send a certificate or whatever to say, I want to get connected and be able to make the query. The way we designed the member match operation, I in very simplistic terms, I think about it, when I go to the doctor, they ask me for two things that they copy. They take my coverage card and they take my driver's license. And magically, I get something, an EOB from my payer. My payer knows how to match to me with that information. So if a member wants data from their old plan, they need to provide that information that that prior payer gave them to go and get service from any doctor.
Michael? And then
Richard. And kind of dovetailing on what Mark's saying, that driver's license works if I go to a doctor in a different state too. So there's that community for the legal and the governance framework that gets reused in a sense from driving privileges to identity. And so that's a very important thing that we could likewise adopt in some regards. Now, I'm not trying to go too far into solution here, but the technology piece that Mark also speaks to with PDEX is essential, but we also need the governance and the trust pieces that he alluded to as well. And that's where this community comes into play, because we're all here as experts, the entire audience of us, not just the panel. And we're here because we care about this stuff. And we need to be that vanguard that leads the way for the rest of the industry.
Richard and Dennis?
Yeah, absolutely. So, as a follow-up, especially in relation to, the various trust frameworks that, arisen in conversations. I think, there's the idea of, okay, what is this required, per mandate for a payer to do, or a provider or otherwise? And okay, do we check off the box for requirement, or is there extra that can be done that could be beneficial, to patient outcomes or to your own outcomes? And so I think that is one of the areas that is definitely kind of that next step that may not, be a specific requirement. You may still have to do one-on-one onboarding, at times. But anything, past that is absolutely an ease and burden. And I would definitely recommend, if you haven't looked into some of those conversations, that it's definitely important. And I definitely agree that WEDI would be a great place to further that conversation.
Dennis, and then Shanna's put a comment in chat. And Shanna, why don't you take a minute and highlight that when Dennis finishes?
Okay. I just wanted to, excuse me, follow up on the question about how you'd know that a member had who their previous payer was. And I think this gets to one of the things that we have to do is as we implement this, is we have to integrate the payer-to-payer across our processes and workflows. So for instance, we have group onboarding processes. One thing that we usually know is we know who their prior payer was, because we have continuity of care processes that go with it. So if somebody's already in the hospital, we know that they're in the hospital and they had an auth, et cetera. So I think this gives us, we need to link into group onboarding. We also need to link that opt-in process into our member onboarding, so that we can make it just a natural part of being a new part of our plan. And it goes beyond that, back to health and care, our health and care engagement, case management, disease management, our risk adjustment, et cetera. But there are many touch points, and I think getting that complete view will help us get more value out of this.
Terrific. Shanna, I'm sure, sorry, I didn't see you on the screen, but you're part of the panel.
Oh, that's all right. I just wanted to jump in. One of the differences actually between the payer-to-payer API and the other APIs in our final rule, which I know I went fast in the overview presentation, but I was trying to highlight a few of those differences. One actually is that the payer-to-payer API does include that unstructured documentation that was submitted by a provider to support the prior authorization requests. So that I did put in the chat the prior authorization data that has to be provided through the payer-to-payer API, and that last bullet is the related structured and unstructured administrative and clinical documentation that was submitted.
Terrific, and there's a couple of prior authorization in this series that we're going to talk in more detail on that. So thanks so much, Shanna. And I see some additional questions popping up, but in the essence of time, I also want to throw out, we've touched on a lot of the barriers. Are there other barriers that we need to be sharing with the attendees today that they should anticipate? We talked a bit about opt-in, opt-out, and attribution and like that, but any comments on other barriers that you're experiencing or anticipating? Ron, go ahead.
Yeah, as the early implementer of peer-to-payer, we have learned many lessons. One of those is the barrier of the point-to-point connectivity that somebody mentioned in the chat. That is important to understand. It's one thing to know what an endpoint is. It's another thing to make a connection and be transmitting members' PHI between payers. That's an important process. That must be secure. You have to know where that data is going. And so we found integrating early, getting a lot of lessons learned early helped a lot. Understanding who you're receiving data for and having good onboarding processes with them. We've run into legal issues between payers. Payers expect, basically a legal agreement between the payers before they're going to make that connection. So there are quite a few barriers my recommendation would be don't wait till the last minute. Get started early. Start testing. You can always test with us. I think probably Scrimshire can test with you. There are several companies that can test with you. But I would start early. Don't wait, because you learn a lot of lessons just doing it.
Yeah.
Richard?
Yeah, absolutely. And just, kind of echo that last part about testing. I know personally, as a developer, I've found that, HL7 Connectathons is a very, very great place to, interact with, other organizations in some of that, specific testing or end-to-end testing. But as far as challenges, I think, there's a lot that we can take back from our knowledge from implementing the previous APIs. We all know the FHIR resources. We know how to, in general, onboard with each other. We know smart on FHIR apps, et cetera. And I think, there are definitely a few points that, are expanding on that. We've already touched on the member match operation, for example. One other topic that I know of specifically that I don't think has been talked about, as much, is how do you consolidate that new data with existing data as it arrives to the new payer. So certainly in situations you can imagine there might be just a contrived example. Imagine someone goes from payer A to payer B and then later goes back to payer A. So now do you have two separate sets of resources for all those, or do you have to find a way to kind of merge those together into single resources? Also, probably a question for myself that Mark may be able to answer. I know you were talking about profiles for limiting, for instance, financial data. Can you walk through maybe what that looks like, from a query perspective? Are you, for instance, doing a query with a profile included? And how does that, limit the data that you're retrieving?
Terrific, Mark.
Okay, so it looks like some of this probably gets into the bowels of technical details. Yes, you could do a query using, to answer your last point, you could use a query using the profile, but in fact, the difference between, for example, a prior auth and a claims and encounter record in an EOB, there's going to be a field, I think it's the class field in the EOB, that would say it's either a pre-adjustment or whatever. So yes, you may want to be able to do those types of queries, and we're accounting for that in how we're structuring the APIs and the export operations. To your contrived, or actually not so contrived, example of I bounced between two payers over the course of 3 years, not unusual. One of the things we incorporated in PDEX in some of the earliest versions, it's still there, is the idea of PDEX provenance resource. And we would encourage payers when they're pulling data to also request the provenance resource, because that was designed. We recognized when we were going through this that payers in many cases are dealing with data that is not originating in FHIR format. Data coming off claims, coming off V2, messages coming out of CCDA, and they may transform it into FHIR. So we actually provided the ability for a payer to create a provenance record that basically said, for example, I got this from this provider or provider organization. It came to me via a CCDA document, and I'm passing it on. And so that would allow, to Richard, to your point, when you're receiving the bouncing back individual and you pull their data, that you ought to be able to find your provenance records that said, I've already got this data, right? The other thing that really addresses, one of the things I think everybody is probably concerned about, is liability. Having those provenance records then gives you the ability, when a member pulls that data down into their consumer app and has a question about it, with the associated provenance record, you're able to say, that's not my data. I got it from this plan, who got it from that plan, who got it from that provider. And the other thing it also does when that data also flows down to the providers through what the APIs we'll talk about next week, is it's not saying anything about whether one source of data is good or bad, but it allows anybody downstream to make their own value judgment about the data they're seeing. So I'd strongly recommend you look at the use of provenance as you're incorporating this data.
Yeah, and just one quick addition there. I know there's for instance, within PDEX, there's a data mapping section that talks about potentially using some of the information provided and that you provide for the member match as well to be able to consolidate records, as well as, for instance, MPIs for providers or organizations as well. So.
Terrific. And I'm trying to manage our time. I see Kevin, you got some comments, and some of those may spill over. Kevin Day is with EdFX, and I think they may be able to go into some of the technical details. There's one dangling question, and Shanna, I don't know if you can answer it or not, but the question's with respect to CMS and Medicare Advantage plans. Will CMS facilitate in any way sharing historical MA plans if Medicare Advantage or Medicare members have changed plans? And I don't know, Shanna, if you're still on or still active.
Yes, I'm here. So we actually will look into this and get back to you. We do have that data. We are looking into what data can be shared in a directory in the future. So we'll take this back and discuss.
Thanks, Shanna. And this is part of what I see as the important role that WEDI plays in this advisor role. And we're, as WEDI, very, very grateful that CMS, ONC are listening in and participating in these discussions, because it provides a very good exchange of information and is very helpful. The final question, and we'll be brief on this, I think we've touched on it to some degree, but how can the industry achieve the objectives of payer-to-payer? And part of that is, are you going to do it internally, or are you going to outsource it? And we're seeing a lot of discussion around outsourcing. But any comments in the last few minutes as to how you're looking at going about addressing this? Or Ron and John, where you've gone down the path, and you can always tell the pioneers by the arrows in their back. You've been there, you've done it, but what advice and how would you share with the attendees? Ron?
That's hilarious. I haven't heard that before, but I'm going to keep it. By the arrows in my back. Yeah, that's funny. Yeah, again,
still alive.
I'm still alive and happy to be alive. It's a very exciting time for us to be in this industry and be working on these solutions. It's really important work we're doing. So I'm very excited, arrows or no arrows. But so if I could really quick, Ferris, I want to make a quick comment on the last question, and that is, it takes more than an endpoint directory to have secure point-to-point communications. And that's confused a lot. We've been talking a little bit about trust frameworks and other methodologies for having secure connections between endpoints. It's not enough to have a big listing of endpoints and think that you're just going to start communicating. There's a lot more that goes behind it, as Mark Scrimshire could talk about. So I just wanted to throw that in really quick. Don't think an endpoint directory is going to solve everything. There's a lot more to that. In terms of,
I warned Rob that there may be an 8th session across all of these APIs just on the topic of privacy and security. It's a common issue.
It's extremely important. It is unbelievably important. But to answer your question, so our approach was a little bit of a hybrid. It's mostly in-house, but we did leverage a vendor to do aggregation for us on our inbound data flows. So inbound data is aggregated and managed by a third party, which works really, really well for us for the most part. It's going to allow you to go faster. They can leverage what they built and have, are operating currently. and then you can leverage going fast, not having to deal with a whole bunch of outside companies directly. You can do some indirect integration with those. So that's how we found we could go fast, and how we got to market so fast. One of the differentiators for us to do that was to be able to use an aggregator as a vendor, and there are lots that you could talk to that will happily talk to you about how to do that, or you could go the full service approach like some other companies here would be happy to sell you that. But we found a hybrid approach was best, at least for how we've been operating up to this point. Now, talking about payer to payer, I see a payer to payer 1.0 and 2.0. And if you look at the crawl, walk, run theory, we've been crawling, and now we're about to go into a light jog. This new version of payer to payer required by CMS 0057 is a whole new ball of wax. When you talk about members hands off, you talk about concurrent data transmissions. There's just a lot more to it, and it's not simple. So look at it early, leverage resources. I can't speak highly enough of using consortiums, because we all have to be in this together as an industry. It's not just passing around data inside our own companies anymore. We have to effectively and efficiently work with each other. So it's important we're all using the same standards. We're all on the same sheet of music, so to speak. And then hopefully there'll be fewer arrows in the back with that approach, Ferris.
So Mark, you took your hand down. Any comment? And then John and Michael, and then I'm going to ask for some closing comments from each of you.
Yeah, I'd say I echo what Ron's saying. What I would say to any of the plans out there is that differentiating yourself on how you implement this is not going to be a benefit. It really, to make this work at scale, we've all got to do it in the same way. So we've got to work together. You know, I'm biased. I am an implementer, but if you look at the rule, it's massively more complex than the original interoperability rule. And so, you know, yes, there's organizations like Ron's that have got the size and capacity to go and build this themselves, but the vast majority of plans, I think, have got to be looking to partner to get this done. I'll sign off there.
John and Michael?
Yeah, and to a couple points, we did Edifax hosts all of our data. So like we provide all the data to them, then they connect, so we partner with them. What we also outsourced completely was, as Ron was talking about, you just can't have a directory of endpoints. We outsourced that to CAQH, and we have them do our attestation. So we direct all third-party apps, all payers, or they've already attested a payer. I became a validated payer with CAQH, so my endpoint's already available, and I'm a vetted good player. So doing that, you know, when you have an EDI team that's doing all production work of 6, I can't be doing pair to pair, you know, testing and implementations. It's already tough enough just doing providers in my county. And also in the area of sharing, because, you know, all the Medi-Cal plans in the state, a lot of us want together with Edifax. We also now have an ongoing work group. We did it during our implementation for payer access, and we're continuing that now. We all meet, talk about best practices. How can we do the same thing? Share what we're doing. So we're doing it as a state group across 10 different plans. And that covers probably 50% of the state. So we've been executing on that already, you know, in our group.
Terrific. Michael?
So just, you know, to take it to wrap up with you, what I'd like to, you know, say to the audience and to even those that are not in the audience, because I think a lot of us are that coalition of the willing, if you will. Just jump in. Don't be afraid. There's a lot to consume here, and it could seem like a big scary monster, but we can do this safely by participating in community efforts like Connectathon events. The advantage of a Connectathon event is that you use simulated data, non-PHI. So it's okay to make mistakes. And you can, in these environments, learn from others. Provides an opportunity for you to develop your technical staff too. so they can go out and learn from other technical folks and from other policy and business folks that understand the requirements. And at the same time, by bringing those business and policy leaders to events and community efforts like that that surround these events, you can have them share their expertise with the technical staff, and also at the same time maybe break down some of the technophobia that comes with the big hairy monster that this sometimes seems.
Terrific. So what I'm hearing, Michael, is come on in. The water's fine. Might be a little chilly at times, but jump in. Let's do a quick fire round the room in a word or two for our attendees. What would you say in terms of the one thing that they should focus on? And let's just go in any order.
Knowledge is power. Just keep up with all the mandates, and then share your knowledge and attend these kind of forums to gain more knowledge.
And from my perspective, I think one of the keys, in addition to all the points made, is just figuring out how you can use this information, expose it, engage the consumer with this information and get value out of it.
Terrific.
I'd say get started now. Don't wait. 2020. Some of these requirements need to be in place for 2026, which, if the metrics mean 1/1/25, so we don't have long. So get started now.
Michael, you're on mute.
Take that first step. Read the first page that's been published in the Federal Register today. Talk to someone at your organization, or talk to someone in the community. Reach out and just try something. Try one thing, and you'll be started down the path.
Karuna and Samantha, what are you saying to your organization?
I would say standardization, to echo some of the points made. This isn't something that everyone has to put their special sauce in, and we're time boxed, and there's cheat codes available. So I think we have an opportunity to really reduce some of the local nuances that come in healthcare if we adopt some of these standards. So standardization.
I would agree with that. I would also just say this is going to be an ongoing learning process. So I think that the conversation today could even look a little bit different than the conversation a year from now, and would love to have this panel come back. Rob, that's for you. And sort of see where we are a year from now, right? And sort of how things have evolved.
Pardon?
Yeah, I would say you need to get started first. I would echo what Mark is saying. And at the same time, I would like to say that first you probably should start doing it because of the regulations, because of everything like that. But as soon as you start, you will discover a very interesting FHIR world, and you will find more scenarios, your challenges that you can solve with FHIR and with all this interaction. So at the very beginning, it just looks like the necessity to do this due to like new mandates or something. But I promise you, eventually, once you get into that, you will have more internal scenarios that you can address with this technology.
Terrific. And Artem, we apologize. We've taken a few minutes of your next section, but I do want to thank, first of all, each of you as panelists, and especially Weedy and the sponsors for allowing us to begin this discussion on peer-to-payer. I'm sure we haven't completed it, but we also want to thank each of you as panelists and attendees for the chat. We didn't get everything answered, but we can follow up with answers on the questions that were posted in chat that we didn't get to. So with that, Rob, let me pass this back to you.
Ferris, thank you for your moderation and a phenomenal panel. I think we all learned a lot. What strikes me, I think, is the fact that we have so much information available to us now on the day that the regulation is published. that's phenomenal. But I think if there's a couple of key takeaways, one is don't wait, get started. The water's if not warm, it's getting there, and expect maybe a few arrows in the back during your swim. But I think I think Samantha said it well. This is not a one and done. I think we're going to be revisiting this issue as part of our ongoing efforts to help the industry implement not just this API, but all the APIs in the rules. So with that, I'm very thankful for our panel. And we'll turn it over now to Artem Sopin. And Artem is a product manager for EdFX and has been with EdFX for more than 20 years. Currently, he works closely with EdFX's payer-to-payer API solution. And here, we've asked him to present a working approach for the payer-to-payer API modeled on real-world scenarios that will help illuminate the attributes for both patients and payers. So with that, I'm very pleased to turn it over to Artem to tell us a little more.
Okay, thank you. Let me share my screen just a second. Stop screen. Okay, yeah. Okay. Yeah, thank you everyone for attending this piece of this session. And
Artem, your slides aren't up.
Aren't up. Okay.
They aren't up. Yeah, they're not up.
Okay.
We have a younger version of Artem on the screen.
Okay.
There you are.
Okay, should be doing this right now, right?
There you go.
Oh, okay. Oh, thank you. Sorry. Yeah. Sorry about that. So the purpose of this session is just to walk through the pair-to-pair scenarios in terms of the rule, kind of how this scenario addresses the rule, and give some sort of educational session. I'll try to speed up just a little bit, taking into account I'm having a little bit less time, but anyway, let me get started here. So basically, first of all, there are challenges. There were challenges in terms of the data exchange between health plans. It's a non-standard transfer where payers must communicate somehow one to another and to get access to the data. The second challenge is like finding out who is the member. And one of the critical pieces is how to identify which data, whose data I'm looking for. And once everything is accomplished, when you know how to connect, whose data you're looking for, then you need to grab this data and start the data ingestion. And we see in each of these steps, there are kind of multiple challenges. And with that, the very first, let me move on, the very first version of, like we call it option 1, it's still valid. It's basically PDEX ESTU1 implementation guide that explains what pair-to-pair is from this perspective. And I would like to highlight this is very first adoption of the IG. In this case, there are two plans, two pairs. I call them new pair and like previous pair or old pair. The idea here is very simple. If member has his account at the old plan, so basically reusing patient access API. So if member still can connect to the old plan, that means he can log into the old plan and invoke the kind of pair-to-pair operation. So the key point here that the account is still valid. The member authorizes this access, and the data can be grabbed. So that's really easy. Moreover, what I liked about this approach, and I still like, that we actually reuse patient access API with this approach, which is important because instead of reinventing the wheel, we kind of rely on existing kind of functionality with patient access API, and everything looks good. But as you may see from my slides, there are advantages and disadvantages of this approach. And the advantage is obviously we can 100% uniquely identify with the member. How? Because we have this member's account at the old plan. It gives you 100% guarantee that who is connecting, you know this person, and that he allows kind of fetching the data from the old plan. The second advantage, we reuse patient access API. Yes, that's brilliant, because anyway, patient access API must be built for in order to comply with 57th rule. So why not just to reuse it? There are several disadvantages here and real life problems. The problems that I've got from several plans trying to use that. It's a member mediated type of approach. Members are not reliable people in all these scenarios. Members forget their accounts, they never register accounts, and they actually really unreliable. Moreover, from the health plan's perspective, it's a very common situation when after disenrollment, when kind of this member is not with this plan anymore, plans just, deactivated the accounts. So this account management was a little bit a hassle. Still, the approach is very, very good. I still love it, but there is a reason why kind of Da Vinci team and Mark moved towards like working on the second version of this PDX AG to kind of to cover this scenario. So let me move on here and see what and show you what the difference. So with new PDX, and by the way, commenting about the rule, the statement in the rule, it says for the kind of current implementation, this what was shown in the first part of the presentation by Shana, there was like a diagram, like a table with the list of required AGs. And if you look back at the recording, you will see that there are some requirements in terms of US core usage, like a version and stuff like that. But basically, overall idea that it should be API and it should be FHIR-based API. However, if you go to the rule, there is a statement about the recommendation. Recommendation most likely means in some time in the future that will be a mandate on that to use option 2 PDX is due to implementation guide. So now there is a reference as a recommendation to use it, even though for now you can use like first option. And the key point in the second option is that actually this process doesn't require any old plans, like a login password, any account at the old plan. The idea is different, that during the enrollment process with the new plan, which is the most logical time to do that, a member can be just prompted for a consent. Think about it as a question during the enrollment process. Hey, what is your old plan? And you say, hey, this is my old plan, this is my old insurance card information, this is what I have. And during this process, you may be asked something like, hey, do you want me, like a new plan, to grab information from the previous plan? In the rule, it's called opt-in. So you basically agree with this idea that you agree, okay, yeah, I allow this new plan to grab the data from the old plan. And from technical perspective, this is what Mark referenced as a consent resource. So behind the scenes, there will be consent resource created and submitted to that old plan. It's basically item number 2 on my diagram, saying, hey, but from business perspective, you may think about it as like a sort of electronic signature where you say, yeah, just I want you, old plan, to share my data with my new plan. So, and that's why I put all these items into advantages. And very important that now this interaction can be initiated by the payer, and there is a certain time frame when you can do it. The rule says opt-in must be offered no later than 1 week after enrollment, which gives just a little bit of flexibility from the technology perspective to the payer. The payer now, the new payer, might collect multiple consents from multiple members, and schedule a time when to go there and pull, because no fresh token is required, something like in the previous scenario. So basically, there are some variations when and how to do this. Disadvantages that we have for now, I don't call them disadvantages that much, but I need to bring something here because there is a reason, there is an active work on the continuation of this IG. And one of them is that, yeah, we have to do a member match. Basically, we have to look for a member in the old plan because now we don't have any active accounts. We don't use active accounts anymore. And the algorithms might be quite sophisticated, and in certain cases, like the match might return you, kind of not return anybody. You might not find, someone at the old plan, theoretically. And still kind of current version of IG is scoped to a single member. And this is the primary reason why there is active work right now. During the DaVinci calls, we are kind of looking for ways to create a group resource, basically to create like attribute multiple members right now and say, hey, I have enrolled 1,000 members in a new plan. And I see that 500 of these members belong to the previous plan B or something like that. And I'm going, instead of like just pulling one by one, in the new version, what we are looking at and what Mark has been talking a lot today, that actually we can just say, hey, give me all data for these 500 members. And here's 500 consents from all these 500 members. So this is going to be a newer version than this one. This one is still scoped to a single member. The actual scenario that we have is, of course, kind of pretty obvious. The kind of member just changes his plan. The reason for that is in my on my slide, member goes from one state to another state. I have these made up plans like changing Wise Health plan to a Great Health plan. People may change plans due to any other reasons, but this is kind of the main trigger for us. And changing a plan means a new enrollment to a new plan. So that's why I was referring an enrollment process. From members' perspective, in the latest IG, the steps that are required is basically during the enrollment process. It can be done any kind of, the mechanism is not described. This is up to a plan. You might have a new account created, member logs into a new plan, you prompt for like, hey, finalize your enrollment information, give us details. And during this kind of like a process, you may ask for like a consent to go to the old plan and execute pair to pair. This is how we see it. And that's why I say the most logical piece of and the time when to do it is enrollment process, because actually this is the time you interact with your members. Once you have finished interacting with your members, usually very often you never see them until the moment they need something, So the next piece, how technologically it's done. So behind the scenes, there is a kind of FHIR AG. I will not go into too many details in this FHIR AG, but think about it as a member enrolls, gives consent, and plan can just do a member match operation. And once it's done, this plan can leverage DaVinci FHIR AG and execute. At this time, still there are three options. It's a query, it's a $ everything operation, and bulk export, even though we think that bulk export will be the better fit, especially when we go towards the direction of exporting data for multiple members. In this case, alternative approach with like queries and $ everything will not be a good kind of fit for this operation. But as of now, still three are options. And behind the scenes, we reuse existing technology, which is important, which is Smart on FHIR, that explains how and which data can be shared and which data cannot be shared. So it's basically technology, how to kind of scope the resources, the data, how to define the data access, and so on. But overall, on the high level, the schema, the flow is very simple. You find the member and you execute one of these operations to grab the data. there should be some outcome, right? So we go through the process, like from enrollment to payer execution. What is the final goal? The final goal is to get the data from the old plan, in our case, FHIR resources, and possess these FHIR resources. So import them into current plan. After that, the usage of these resources can be can fit to any scenario. It can later be a new provider access API call. It can later be patient access API call. It just sits in your FHIR repository at a new plan, and you have latest and greatest data from the old plan. So this UI is basically a demonstration of what we have at EDIFAX. So we put provenance on the data that was imported from the previous or past plan. But technically, all these are FHIR resources. And with that, you can reshuffle through those resources. So you can build the UI on top of those resources and just render them. And of course, what is important just from common sense is to track all interactions. So when you execute pair-to-pair, you need to note down information about that. Hey, I've actually connected for this member to this plan. This happens on this date and time. You see what I have here, like requested on this date, received completed on this date, and the status is complete. So actually, I've executed what was required from me as a health plan to grab the data from the previous plan through consent given by this member. This is an outcome that is essential to have, right? And let me move on. So the key considerations here that basically we think that onboarding pairs is really important. And one of the questions was asked about how pairs know one about another. The discussion continues, and during the connectathons it continues. So we are looking towards certain trusted network. And the latest version of IG also recommends maybe even not only recommends, but forces you to use MTLS to simplify the dynamic client registration. So basically the idea is pretty simple. You just onboard, you find out which other plans are registered there, you register your client IDs and secrets automatically, and you can connect to another plan. So you just need to have some, sort of trusted network where you can do this. And with that, I would like to wrap up, taking into account I wanted to leave some time for any questions and comments. I hope this presentation was useful. I tried to keep it very high level from the business perspective only. If you're interested in technical details, you can contact me directly. I will be really happy to talk about things like tokens, connectivities, and this type of scenarios. So with that, if you have any questions, please, any comments, please go ahead.
Yeah, any questions for Artem? And as well, Michael, can you unmute Kevin Day, if you don't mind? I think he's got a comment.
Already did.
Oh, perfect.
Hope you guys can hear me.
Yes. Go ahead, Kevin.
So hey, I'll just add two things to what awesome job, Artem. So Artem and I've been working together here at EDIFAX for quite a while and with a number of our clients. Two things I want to point out. One was very subtly in the screen. We kind of gave you a bit of a preview of there's I think Mark talked about it when it comes to provenance, and there's provenance of the clinical data, but there's also provenance of who the actual previous plan was. So when you're ingesting in it, because you may have situations where individuals bebop around a couple of different plans, possibly, especially on the ACA side, I've seen where they actually have insurance over, a 12-month period with across 3 different plans. So you may be getting content in on a P2P exchange from a multitude of other payers. So being able to know which records came from what payers, that's where the provenance just from the sourcing side, not the clinical provenance aspect of that. That's one thing. The second thing was we as an organization have a sandbox for a number of use cases, including P2P. We welcome you to go ahead and contact us. Artem gave some of the contact information above. We'll be happy to work with you on any kind of P2P testing that you want to do with us.
Appreciate that, Kevin. Doesn't look like we have any questions. Artem, I don't know if you want to make any closing comments.
Yeah, okay. As we don't have any questions, I just want to thank you for all contributions, to everyone who's participating. Still, there are many so hot topics in those discussions, and I appreciate patience, especially Mark's patience on the development of these IGs. And I think we have done, all together, I say we because we also contributed by commenting, a great job, and the scenario becomes more clear, more straightforward, and I hope the newer versions of IGs will be even better. And I really want to encourage you, just give it a try, comment on what is described inside those IGs, and if you see any problems, any concerns, just post your questions. We need more and more feedback on that. So we appreciate kind of any comments from any angles, like whatever experience you have. So I want to thank to each and every participant, and thank you.
Excellent. Artem, thank you. And your colleagues at EdFX as well. As we'd like to thank MCG for their sponsorship as well. So I think we have got just a wrap-up slide. I wanted to remind folks that the conversation does not end here. Our current board chair, Ed Hafner, is going to lead the post-game show and talk about some, go into more of a deep dive into some of these issues. I think you can tell there's a lot to unpack here. So definitely encourage you to get involved with this work group. And again, anyone in your organization, if you're a WEDI member, can take advantage not just of the series, but also get involved with our emerging technology work group. And then again, thanks to EdFX and MCG. The one thing that, again, we've learned here is, boy, this is going to be a challenge. So look to experts in the industry to help you and guide you through this process. And again, I wanted to remind you that we are going to turn our focus over to the patient and provider access APIs. That will be from 1 to 3:30 next week on the 15th, right after Valentine's Day. And with that, I wanted to wanted to thank a few folks. Big thanks to Shauna and Mark for their tactical overview of the rules. Big thanks to Ferris for moderating a phenomenal panel. So thank you to Samantha and Mike, Artem, John, Dennis, Richard, Karuna, and Ron. And as I always do, I want to thank our own Michael McNutt for being the expert behind the scenes, making sure everything runs so smoothly. So with that, we'll close out. Have a great afternoon, and we look forward to seeing you next week. Take good care.